Hello and welcome. Let's talk about antiparkinsonian drugs. So, the aim and objectives of treatment in Parkinson disease is to restore the normal dopaminergic and cholinergic balance by increasing DA activity and reducing ACH or acetylcholine activity. Now, drugs include replacement of the dopamine by levodopa, dopa decarboxylase inhibitors like carbidopa and benserazide, and inhibitors of the DA metabolism like MAO-B inhibitors, siligilin, resailin, COMT inhibitors like entacapone and tolcapone, and dopamine receptor agonists like bromocriptine, pergolide, pramipexole, ropinirole, and anticholinergic drugs like benztropine, and release of the dopamine and inhibits reuptake by amantadine. Now, let's talk about levodopa. It is a primary drug or prodrug, and it is the immediate metabolic precursor of dopamine. Mechanism of action of levodopa. Levodopa is a prodrug. Dopamine cannot cross blood-brain barrier, so levodopa enters the brain and it's converted to dopamine by dopa decarboxylates and improves the Parkinsonism. Levodopa is usually given with carbidopa, which is a peripheral dopa decarboxylate inhibitor, which inhibits peripheral conversion of the dopamine and increases the CNS availability of the L-dopa, because carbidopa does not cross blood-brain barrier. It is well absorbed from small intestine. Now the large portion of this drug is inactivated by MOA in the wall of the small intestine. Levodopa and carbidopa decrease the requirement of the dose of the levodopa by 75%. Now this is a picture showing the action of levodopa alone, while the action of the levodopa with carbidopa is increased, where 10% in the brain in combination and alone 1 to 3% only is seen. Now, clinical uses includes Parkinsonism, where it is a primary drug for this disease. It can improve all symptoms, especially bradykinesia and activity of the levodopa declines over 5 to 10 years. Adverse effects includes anorexia, nausea, vomiting, and the tachycardia, postural hypertension are the most common serious effects. Dyskinesia is seen in 80% of the cases, which is dose-related. And the most common is the choreoathetosis of the face and extremities. Anxiety, insomnia, somnolence, depression, agitation, confusion, depression, delusion can be seen. And on and off phenomenon where there is fluctuation of the clinical response not related with dose may be seen. Off periods of the marked akinesia alternate over the course of a few hours with on periods of the improved mobility but often marked dyskinesia. Exact mechanism of action is unknown, and the rescue drug in this case or this side effect is apomorphine. Other side effects like mydriasis, acute attack of glaucoma, brodysclerosis, hot flush, aggravation, gout, etc. can be seen. Drug interaction. Pyridoxine with L-dopa increases the extracellular metabolism of the L-dopa and decreases therapeutic effects. MAO inhibitors with L-dopa may lead to hypertensive crisis if drug is discontinued. Contraindications include psychotic patient, glaucoma, active peptic ulcer, cardiac dysrhythmia, malignant melanoma, or suspicious undiagnosed skin condition. Now, drug holidays. It is no longer recommended. Drug holiday 3 to 21 days of may temporarily improve levodopa toxicity, little help in the management of on and on phenomenon. It carries the risk of the aspiration pneumonia, venous thrombosis, pulmonary embolism, and depression. Dopamine receptor agonist. These are often given in combination with levodopa, and these include bromocriptine, pergolide, pramipexole, and ropinirole. The advantages over levodopa is not required enzymatic conversion to an active metabolites, no potentially toxic metabolites, do not compete with other substances for active transport into the blood and cross the BBB, and limited adverse effects like less dyskinesia, less fluctuation response. Now, disadvantages over levodopa includes less efficacious, behavioral effects are more common and severe than levodopa, and may induce profound hypertension after initial dose. Serigilin. It is a selective monoamine oxidase B inhibitor and decreases dopamine metabolism in CNS and prolong the action of the dopamine. It should be avoided in patients taking SSRI, TCA because it may precipitate serotonin syndrome. Now, entacapone and tolacapone. It inhibits catecholide O-methyltransferase enzyme, and entacapone acts only in the periphery and decreases the metabolism of the levodopa, so increases concentration of levodopa in brain. Tolcapone acts both peripherally and centrally, and it inhibits degradation of the dopamine in brain. Tolcapone may cause acute fatal hepatic failure. Amantadine. It is an antiviral drug and it increases the release of the dopamine in the CNS by an unknown mechanism. It is useful in the early stages of the Parkinsonism and can be used in combination with levodopa. The therapeutic effect may diminish in a few weeks. End of the topic.